let's get going. Thank you all for joining us. It's really great to have so many of you here with us tonight. I'm Neil from the BSR Comms team, and I'm here as a facilitator for this evening's webinar. We have moderators working in the background as well, who've been managing your questions for our speakers and any other queries that you might have that pop up. You'll see we have our guest speaker and our guest host here. So our speaker is Lizzie MacPhie. Hi, Lizzie.
Hi.
And our host is Marwan Bukhari. Hello, Marwan.
Hi.
Thank you both for joining us, and thank you everyone else for joining us as well. I'll just quickly outline how the webinar works before I hand over. We are scheduled to be finished at 7:45 tonight. There is a chat function on the right of your screen. Many of you are already using that, which is great. This is where you can post your questions for our moderators. If you're on a mobile device, you should have a chat icon in the bottom right of your screen. If you can't see that, just give your screen a tap and it should appear for you. A reminder that this is a webinar for rheumatology professionals, and as such, we aren't able to tackle specific patient questions, I'm afraid. We do have a poll open this evening, which you can answer at any time. One of my, Steph, another host, could you load that poll up for me? Thank you. So there'll be a poll. Here we go. Thank you very much. On the screen now. You can answer that any time during the webinar. In the first section of tonight's webinar, Lizzie and Marwan are going to talk through some of the common questions that we've had in since our webinar a couple of weeks ago. And they will then tackle some of the questions, as many questions as we can from the chat that you've posted through this evening. After that, we'll close things off with any final comments and details of our next webinar. If you need to leave the session at any time, you can do so by just closing your browser. We are recording tonight's session so that we're able to make it available for you to watch again. We will contact everybody who's registered to let you know when that is available. If you have any tech issues at any point, please try to refresh your window, and that should tackle any issues that might pop up. Other than that, I'm now going to hand over to Marwan and Lizzie to get us started. Thanks very much.
Thank you. Right, Lizzie, let's get things going. I mean, a week is a long time in COVID, isn't it? So there's been quite an interesting amount of developments. So let's start off with the BSI guidance. What's happened in the week? What's been updated?
So we had an update this week. We tend to refresh the guidance on a weekly basis. And just to highlight to members, what you will see each time you log in and upload the guidance and go onto the web page is you'll see what looks like a very familiar document, but there will be sections that have been updated with the latest information or new guidance that's come out. If we've had any major updates, then what happens is we will send out an email to members just flagging what's new. And so that's just helpful to help tease out if you just want to sort of look at which sections have been updated. But there's quite a lot of stuff that's come out this week, which we highlighted. So we've had quite a bit more information from each of the devolved nations about how they're identifying their patients for shielding.
Yep.
And so that's all now been uploaded, and all the various links, and understanding the processes that each of the devolved nations are going through to identify those groups. We have also had an update of the NHS England guidance for rheumatology. There's just been a few subtle changes within that. So that was something that was already up, but that has been updated already by NHS England. We've also had some updated guidance around children and MSK conditions, just flagging in children with respect to what warrants urgent referrals at this time, what we should be prioritising, and that really complements what's been done for adults. So I think that's helped our paediatric colleagues.
What happened to the scoring grid, though?
Sorry?
The scoring grid that accompanies the stratification has been taken down. What's
Yes, so the scoring grid was taken down, and that was a difficult decision that we made, but the scoring grid was designed to complement the stratification guide for identifying those patients in the shielding group. But we were became aware that what it was doing was there was just very subtle nuances where it was differing to the actual guidance in the document. So what happened was we developed our guidance in the table with the 3 columns, identifying those in the shielding group, those at what we were referring to as high moderate risk, and those in low risk. And it was mostly based on medications, the immunosuppressive medication, steroids, age of patient, and comorbidities, as you remember. But what happened was it was quite difficult for people to sort of work out on an individual patient basis where each patient sat. So what was developed to complement and to help people identify the patients in the shielding group was the scoring grid. But there were just a couple of instances whereby it wasn't giving the information about those patients who were in the moderate. So it's very good at picking up the shielding. So if you scored 3, then it immediately was able to identify those patients who fitted into the shielding category. But it was those that were scoring 1 or 2. There was some subtle discrepancies between what the guidance, and we felt that the process of identifying those patients in the shielding group in England has been completed. Everyone should have had those details into to their Trust COVID-19 leads last week, which then will have fed into the national registry. And we did have a discussion about whether we change the scoring grid so that it's absolutely in line, or whether we take it down. We felt that the sensible thing to do is, rather than have different versions up, which might cause confusion, was to take it down and acknowledge that the actual guidance is still there. That's still what we are all following, but just to avoid any confusion.
Okay, there's one question about sulfasalazine that came through, saying, how come it's, it doesn't interfere with lymphocyte function. So why are we still, why is it still at the low risk there?
It's felt with it being immunomodulatory rather than being immunosuppressive. That was the reason why it was put into the group that wasn't associated with any risk. Same with hydroxychloroquine as well. So it was more the mechanism of action, though I appreciate that there's aspects around lymphocyte function. But I think that was how it was viewed when we were putting the guidance together.
Okay, and talking about drugs leads me very naturally to the H number, hydroxychloroquine. What's our concerns? What about the trials? I mean, there's contradicting stuff all the time. We've got an island-headed head of state saying it's the best thing since sliced bread and convincing everybody to stockpile it.
Yeah, and I mean, and we brought this up, we discussed this last time, didn't we, Marwyn, about the concerns, because we've obviously got a cohort of patients who take it for their underlying rheumatological condition. So with respect to the information that's coming out about hydroxychloroquine, we have got, I think it's fair to say, most of the data that's coming out doesn't really support that it's got a protective nature or such, and there's worries about if we go giving it to lots and lots of patients, this drug does have some quite serious potential complications if you give it to enough people. There's been some information come out of a study in the New England Journal, which was about use. So they looked at a number of veterans who were on it, and interestingly, actually, it appeared that people who were on the medication were doing worse, and there was a higher death rate. I think there's also been a letter in the Lancet published from
India.
Colleagues in India, which really raised concerns, because there was some suggestion of using it as prophylaxis treatment in healthcare workers, and there was real concern raised as to what's the evidence for this. If we're giving it to these numbers of people, this could be very dangerous. We know it's one of the arms in the recovery trial, and I'm aware that there's a primary care study which has been launched in this country looking at its use. So I think it's fair to say we don't know the answers, and it's a bit of a mixed message that's coming out, but there's not huge amounts of evidence coming out to support its use and that it's got a protective function.
Yeah, well, there's three elements to it. Is that is it stopping you from getting the disease, and having got the disease, is it stopping you from having severe disease, and then having severe disease, is it stopping you from dying of the disease? And I don't think any of those four questions have actually been addressed. All the observational studies have suggested there's actually really nothing happening here. So that's how we're going. There's a question that's come through about non-English speaking patients, and I can completely understand that it could be quite complicated, our communication in general with them, but our communication about shielding and protecting and everything else. Do you have any updates about what we're going to be doing?
Yeah, so I think one of the challenges for us at the BSR is that we are a member organisation, and the guidance that we've been produced has been for our members. It's been a very, very difficult decision to make, but we haven't got the resources for producing patient-facing guidance as well as guidance for our clinicians. It's very time consuming. We've got obviously our office staff are all dispersed at the moment and working remotely. So just keeping on top of resources that are for our members has been our priority. And as I said last time, we've looked to work with our patient organisations and affiliations to produce guidance that supports our patients. And I'm aware that there are a number of consultant rheumatologists who've shared with us, and a number of these have been shared on the BSR members forum, links to videos that they've produced for their populations who are non-English speaking. So I'm aware that one of our colleagues has produced a video which I think has been shared through NRAS, and people have developed guides for their patients, which they've been very kindly sharing. And I would encourage all of our members to do that through the BSR members forum, because that's how we can share these resources. But we just don't have the capacity within the BSR to produce that patient-facing guidance, and we've had to be quite firm. This is for our members, and yes, it supports our patients, but there's a lot of resource goes into developing those sorts of things.
Well, actually, throughout there, we've had I think a countess from Birmingham who's basically is quite happy to provide some help with that. So if you, I think we've got to get in touch with the BSR to offer things, that would be great. And there's also the BSR SIG group on ethnicity, which Murthy has just sort of mentioned in the chat on the side. Now, I understand that we did talk about interferon, and we actually answered it because it was done at the last webinar, and there was a formal response sent back to the few patients on interferon.
Yeah, so we view that as another biologic drug. It's not quite as immunosuppressive in action as quite a number of the other biologics. We included just biologics that were NICE approved, which was why I think it's fair to say we didn't include it in the guidance, but I've sent a response back to Priyanka, who asked the question, and she's forwarded that to all the other BSR leads at the specialist centres to just say that, class it as you would the biologic drugs when you're looking at that stratification guide.
Okay. This is a live question. I thought we'd take some as we're going along because they fit naturally where there is. So guidance about how long after a typical COVID symptoms should restart medications, especially methotrexate.
Yeah.
The answer is how long is a piece of string, but over to you.
Well, at the moment we're in evidence-based medicine zone, aren't we? And it's not a nice place to be. We'd love to have some, firm evidence of what to be saying. Funny enough, I had a conversation just today with a patient, and about this very issue. She's had COVID 3 weeks ago, and she's still got quite a niggling, barking cough, and she's been apprehensive, about restarting. But she's otherwise very well in herself. She's not having any fevers. It's just this persistent cough that she's got, which is starting to settle. But she's been off her methotrexate for the last 3 weeks. And I said, look, if you're feeling otherwise well in yourself and it's just the cough, I said I was happy for her to restart. And I think that's probably the approach. I don't know what approach you're taking, Marwin.
Yeah, that's exactly what we're doing. I mean, we say that the cough is exceptionally common. As long as the fevers have stopped and the myalgia and the other symptoms, cough and fatigue, we're ignoring and just saying, right, you can restart, a week after you had your last symptoms. There's been lots of questions coming through, but we thought we'd go through a few that we would particularly like to cover. So how are people going to get back to dealing with the backlog? I mean, a lot of us have been, we've got a red, what we call a red COVID ward. So I'm looking after a bunch of patients who have a ceiling of treatment, who we have to go and do a ward run on every day. And I'm very aware that my rheumatology work is actually still there waiting for me when I get back, including reporting DEXAs and seeing patients with flares, etc. How are departments going to get back to normal? Is there a guide?
Well, the NHS England has provided some guidance on what hopefully has supported departments' aspects of their care to keep going, things like advice lines, keeping going with seeing new urgent referrals. So hopefully that's been able to support discussions with managers to say what's priority to continue at this time. I suspect that all of us will be in the situation that we've had all of our, if you like, routine appointments at this time paused and had to be cancelled and rescheduled. We've rescheduled everything from July onwards, but now our next routine appointment is running into October, and I suspect that's going to be commonplace for lots of departments. So with respect to, we're going to be for some time redeployed to supporting our colleagues in acute medicine, and it's very challenging even if you've got the capacity at the moment to assess certain patients by telephone appointments. It's possible to do certain aspects, but I think lots of us feel that the patients still, lots of new patients particularly, need seeing in person. And we've particularly enjoyed the move to telephone appointments with our follow-ups, and I think that's gone down really well and has made us think about whether there's capacity in the future to continue, certainly with aspects of our care being delivered in that setting. But sort of how we recover the backlog it is the big question, and we're doing a piece of work at the moment with the Royal College and with the RCP to help identify what our priorities are and what things we'll need seeing within what timescale. And we've been asked to provide some information about numbers and such of patients that we see and what types of investigations, just to try and give some guidance to how we try and reorganize services as we get back to normal working and pick up this backlog.
For example, we've done quite well. I'm using this sort of medium to communicate with my patients. We have a virtual rheumatology waiting room, and the patients just turn up there, and I just go through the waiting room at the designated time and have this sort of like Skype type interview, which is fairly secure. So we've actually managed to sort it out locally, but I suspect not everybody will have the ability to print to a local pharmacy or request tests and x-rays electronically, but we've got that up in Morecambe Bay. So are there any new data on the rate of deaths amongst rheumatology patients? I mean, from what I've seen in the journal, there really hasn't been very much of a signal. Do you think we've overreacted?
I don't think, I think it's dangerous at this stage to, and I would be very mindful even in the future if we look back and say, did we overreact? Because none of us have known what this was going to do, and we were all in unknown territory. And I think the measures that have been taken have been all very, very, very sensible, given what limited information we have about this virus. And some may argue in the future, well, have we been overcautious? Have we? But it's best to have that approach than be caught out the other way is my way of looking at it.
Yeah, I mean, from the general point of view, all I've seen is, very mild disease in all of the patients who are on immune suppressants. So we'll have to wait and see.
But I suppose the bit that comes to that, Maureen, is, and I think it's a real opportunity to promote the global COVID registry that's going on for MSK. So we've got the global registry, and for us in Europe, we've got the EULAR COVID-19 database, which plugs into the global registry. And I would very much encourage people to upload their patients. So if you are aware of any of your patients, irrespective of the severity of their illness, but if they are a confirmed case with a rheumatology diagnosis, rheumatological condition, then please upload them to that database. I did my first one actually today, and it took me 7 minutes. It's not overwhelming information. It's all anonymous. You don't need the patient's consent. You don't need for it to be signed up by the trust. It doesn't need research permissions. The only data that they sort of request that it traces back to someone is your email and name and the institution you work for. But otherwise, all the information about the patient, all they request is the age of the patient.
Okay.
And I think that will help to give us some information, but obviously that's going to take time for us to find out what's happened with our patients. But they're up to, I think the data, they did their first sharing of data on the 21st of April, and they've got 249 patients have been registered to that. And I'm very proud to say that 92, so the highest recruiting country was the UK. Spain came in next at 77. Interestingly, I think Italy are still recovering. They only had one patient uploaded. So
they're trying to keep the data to themselves. There's been quite a lot of noise there from the fact that our BME, the BME group, has been disproportionately affected, especially with the healthcare group and with patients as well. Is there any evidence for vitamin D? I mean, there is some guidance that we should be taking vitamin D, but I'm not too sure where that sort of came from, considering the fact that, as you can see, the weather's fantastic. So we should be able to get our hour of vitamin D when you have your exercise.
Yeah, well, certainly the BME group are certainly looking like the outcomes are worse in that, I think that's across the board. That's not just within it's rheumatology patients. That's across the board. That's something that's been commented on, and particularly in the States. With respect to the vitamin D, interestingly, in our guidance, we have signposted people to the guidance that was published by NHS England to encourage us all to take some vitamin D supplementation. And though the weather is wonderful, we are probably not spending as much time outside as we normally would, given that we're all in our houses. So I think there's a good justification for us taking some vitamin D supplementation at this time, especially if there's a feeling that it may help to boost your immune system. So who knows? It'll be something that will have to be looked into in time. But you wonder whether vitamin D maybe has some role to play.
Well, it might just be more complicated than that, because Francis also mentioned that the number of deaths in India are quite low, and if you think that you've got a populated nation that will have a low vitamin D, it's there. While we're getting some of the questions through from the floor, do you think that it's beginning to become less common? I mean, the amount of deaths being reported is sort of like plateauing, if not falling. At least in my hospital, the number of new cases aren't really going up. They're actually going there. So in the provinces, we seem to be getting much less of an acute spike, and patients are not coming into hospital as much as staying at home for longer. So we're running at 60% capacity in most acute trusts. Do you think that this will have a backlash? So when they tell us, right, we don't need you anymore, we go back to doing rheumatology, do you think we'll have the second big spike of patients coming in and the hospital's not coping?
Well, I think that's going to be what we're watching out for, isn't it? I think it's fair to say that we've been fortunate. We both work up north, and we've been fortunate. I think that the social distancing measures in some areas have just kicked in at a time that has stopped that sort of exponential rise in cases that was seen down in London, and we've been able to prepare, clear hospitals, clear wards, and sustain that, getting enough patients out at the same time as the admissions in. In Preston, they've had pretty steady numbers coming in, but at the same time being discharged, and pretty steady numbers on the ICU. So I think we have benefited, certainly in further up north, and probably rurally as well, from having some time to prepare, which was what unfortunately our colleagues down in London didn't have time to prepare. And I'm aware that obviously there's other places being pretty hard hit as well. Birmingham is as well as another example. I mean, we've heard all these stories about the extra bed capacity being created outside of hospital settings. So these, if you like, emergency hospitals being set up. Funny enough, my job last week was to get involved with the setup of one locally, but then it's been decided to pause that because we're just not seeing those numbers rocketing into hospital, which is obviously a good thing. But the question mark is, will it happen, or will it start to pick up again once the social distancing measures and the rules are relaxed?
Well, actually, the only hospital in London that's really struggled, from what I've heard, has been Northwood Park, and all the other hospitals are coping fairly well. The Nightingale in Manchester only has 4 patients in it as of yesterday. I think, we might have, there might have been a slight, overreaction for what we need to do. And I think everybody has to go back and look at this service and start to go back to have a think about how we're going to get the service back.
But again, if we hadn't, if those units hadn't been put in place and we've been overwhelmed, you need to at some point make that difficult decision to get those units up and running, and they have been done very quickly at expense. But it's far better to have them there as those backups and that insurance policy than not to have them. So
Yeah.
I think I'm a great one for that. Hindsight, there's value in hindsight, but I think at this time we need to be careful about being too critical when we're dealing with, with people's health and resources, and keeping as many people as we can safe and in a bed, and not having to make those difficult decisions of who we treat and who we don't.
Yeah, it is quite tricky. One question that I'm sort of hearing from some of the comments that are scrolling through: are we going to revisit our decision on taking the risk that blood tests don't need to be as frequent while COVID is occurring? Is that going to be looked at again? So patients are very frequently saying, I used to have monthly blood tests, and now I'm not having monthly blood tests. Does this mean I'm less at risk? What's going on? It's the risk balance of catching COVID if you come in to have your blood test versus having a side effect from your drug is actually quite a tricky one for most rheumatologists.
Well, I think there's 2 aspects to this. I think there's probably 3 aspects. If you think you've got your patients who are new starters, who are having the blood test done more frequently, when you're more prone to getting abnormalities on your bloods and action needing taking. So I think that's a difficult group to step back on. But certainly on those stable patients, and one of the things in the NHS England guidance is that they did just give us some scope to say that in stable patients who've been on treatment for who's been stable for a couple of years, you might think about reducing their frequency. The updated BSR guidance on DMARD monitoring did reduce the frequency in across the DMARDs to every 3 months, and I think it's fair to say that probably not every unit might have gone that far as to doing that. I'd hope units have, but I think for lots of patients this might have just given departments an opportunity to say, look, it can move to 3 monthly in drugs if you're stable. So I think that's what we've very much encouraged is that the BSR guidance says that you can move to 3 monthly bloods in patients who are stable, and please make sure that is prioritised. And I think it's fair to say with the biologics that a lot of units we've heard are reducing down to 6 monthly bloods with patients. So again, it's probably an individual patient choice at what stage they are in their treatment pathway as well.
Yeah, well, the one drug that we worried about most was subcutaneous tocilizumab, because, as you know, there is an arm of the recovery trial now. They've just done an amendment that we're going to be using tocilizumab for treating patients who are in hospital and have severe disease. But on the other hand, we're worried about liver function abnormality and late onset neutropenia in these patients. So it is quite tricky. There's been a question about lymphopenia. As you know, lymphopenia is actually one of the markers for you're having, if you've got stage 2 disease and you're lymphopenic and your D-dimer is up, then your chances of progressing is quite high. So what would you reduce immune suppression if somebody's lymphopenic? And would you, if they're stable, you just check for symptoms? This is a question from Priyanka, but there's been quite a few people who've actually asked that question as well.
I mean, again, we're on an evidence-based lacking environment. I have to say, I think on my own, I can only speak for what I do personally. I don't think I would adjust patients' treatment at this time on the basis of having low lymphocytes, but I would probably be more proactive about alerting patients to symptoms to look out for. And just making sure that they know to make contact with the relevant NHS coronavirus hotline and be seeking medical advice if they fall unwell. I think that's the approach I would take personally.
Yeah.
I don't know about yourself.
We've just taken a pragmatic view that it's really about symptoms, and patients who tell me that they're feeling fine and their lymphocytes are low and they have been low before. I just say, listen, just as long as you're doing what you need to do, you know, we'll be going on. Jagdar has said that there's already been a large study in Italy of tocilizumab. It should be, it should have been out on Friday last week. But unfortunately, we don't seem to have seen it, and I'm not sure whether it's about how to disseminate these trials quickly, mainly because the peer review can be a problematic. I'm sure you're very aware that the Annals of Rheumatic Disease pushed the pace of paper pushed the paper through very quickly, and has been severely criticized by the lupusologists internationally. And so we have to be very careful about getting things non-peer-reviewed and scrutinized before we publish them. So that's a lesson for everywhere. And in fact, the hydroxychloroquine study, for example, that we mentioned earlier.
Yeah, you're talking about non-peer-reviewed, isn't it?
It's not been peer-reviewed. Yeah. This person did it. The first hydroxychloroquine paper was actually pushed out on Twitter. So it's really quite tricky. But I think you have to just be very sensible and use your clinical nous. And I think the sort of webinars where a lot of us can get together and actually, you know, share what we're doing and just reassure each other that what we're doing is reasonable is not a bad idea. So that's happening there. Well, there's a question there from Kathy. Can you explain what will be happening with developing guidance as social isolation is relaxed, in particular suggestion of schools reopening? In relation to children's risk, but also parents who are shielding and have children returning to school. This is quite an interesting one, mainly because people are thinking that children are a vector, and the herd immunity will develop infecting each other. And as long as they don't go back and see grandparents, they're okay. What do you think?
Yeah, so interestingly, Kathy and colleagues from BSR shared some papers today about children and their them transmitting the virus, which maybe isn't quite as we thought. I think it's fair to say, but I think it's a real challenge because there's going to be some children who are in that shielding group who we're advising should shield, and yet that comes in the context of we know that children don't get the serious complications as commonly, so you've got to balance that. And then the other challenge that we have is children returning to school when their parents are shielding, and them coming back. So there's sort of two bits to it. And one of the challenge for us is at the BSR is that, you know, our job, if you like, is being to identify those shielding groups. And I think we need to really work with Public Health England as to how they're going to support these groups, the children of patients who are shielding, but also children themselves who are shielding. How are we going to support children? Because this isn't an issue that's applicable just to rheumatology. This is going to be across lots of different patient groups. So I think what we need to be doing at the BSR is pushing Public Health England and also the paediatric societies, Royal Children's Health, is how are they going to support children and families in these groups.
There's quite a bit about what happens if somebody is actually supposed to have been shielding and hasn't got a letter. I mean, I've had a patient who is the wife of a colleague, and he said, my wife is high risk according to the grid you told me to do, but she hasn't got a letter. What would happen that way?
So the shielding it's been slightly different across, and it's worth saying that the process is highlighting that the process is different in England as it is in Scotland and in Wales. But we've now got the guidance from Scotland and from Wales as to how they are identifying their patients and sending letters out. So in England, we should have identified all of our patients by last week, and it was the responsibility of rheumatology departments to identify their patient groups. And that was tough because lots of people had already redeployed and departments were struggling. And I'm aware that different departments took different approaches with that and how to notify. But what happened was, once you've identified your patient group, is that every trust has a COVID-19 trust lead, and they have access to a central database, and every day they can upload patients via a spreadsheet, and within that spreadsheet you can just document that the patients meet the Academy of Royal Medical College's guidance. So that's the box that we tick for our rheumatology patients as to why they fit to the shielding category. And then once they're onto the central system, then that gives patients the ability to access additional services that they might need at this time. We were initially informed that it would all be done through the GPs, and we'd alert the GPs and they'd put codes on their systems, but the process changed. We still alerted all of our GPs and sent them a letter to say patients were on that, but it's only when the patients are triggered by either their GP or their specialist via either the GP route or by that central register that they then officially get on the list. So that's what's happened in England. If a patient has not received a letter, but they're pretty sure that they're in the shielding group, what I would advise is that they contact their rheumatology department, because we can still add patients through our trust lead. So even though we were meant to have done it, but the deadline was last week, they will still let you add additional patients. And so then they can access things. And I know that lots of people have got alerts from Public Health England that have come through, and we've had lots of patients receive texts to say that they're in the shielding group, and we know that some of these have gone out and yet they don't actually meet the criteria. So we've had lots of questions about that. I don't think our job is to unpick people who might have inadvertently been sent, but if patients are phoning us and asking us, this has definitely applied to me, we can give them the correct answer. But nobody's going to come round and police and make sure they're staying in the house. So it's just that case of understanding the processes of how people get alerted. And patients can self-register. They can go on to the Public Health England website and they can self-register, but a doctor, either their GP or their specialist, needs to provide the assurance to the system that it is an appropriate case for shielding.
Okay, there's been a suggestion that we actually add a question to the COVID-19 app to ask if patients are in a shielding group. Maybe that will give us some information. But I think we're beginning to, our time is ticking quite quickly. But there's a really good question from Amelia, is what are your feelings about escalating patients to biologics during the pandemic? Is it better to get the disease under control, or is it better to avoid immune suppression? My department is completely split 50-50 into yes, treat the disease aggressively, or no, we better wait and see. So what's your feeling?
Well, we touched on this. Again, we're evidence-free. I think it makes sensible to have that informed decision and a shared decision with your patient, because I think actually lots of patients are actually quite apprehensive at this time about escalating their treatment. So I think we've had lots of patients where we know their disease is active, and we've had those discussions, and they've decided that they'll hold off for the moment, especially people who are starting new biologics or switching to a different biologic. That patient group's been particularly apprehensive about changing at this time. And I think it's fair to say within our department, I think we've been apprehensive about those sorts of changes. But if patients understand the risk, we know that there's an increased risk of infection in those first sort of 4 to 6 months of starting treatment. So that's something to bear in mind. So it's difficult, and I think it needs to be that shared decision with the patient, and to think about drugs with shorter half-lives that if there are problems can be stopped. So you think about, or if you're changing or escalating someone's DMARD, think about adding in something like sulfasalazine rather than another immunosuppressive agent.
Yeah, if we can get the shorter half-life drugs delivered, we've got problems with delivery of as you know, in our region, that certain companies won't register new patients. There's a specific question. I'm not sure that there is a discrepancy anymore. Is there a discrepancy between the BSR and Public Health England about shielding?
So there's not. So the Public Health I suspect the question is the NHS England guide, because that stratifies our patients into very high risk, moderate and low risk. And most of our patients fall into the high risk and very high risk group. So that might be where the discrepancy is. because the guidance from NHS England came out before the shielding stratification was designed, because that was another process. The only thing I can think is that the Public Health England guidance talks about vulnerable patients, and most of our patients fall into the category of vulnerable because they're prescribed immunosuppressive agents, but that doesn't necessarily mean that everything meets the shielding criteria. So that's where we've got to be careful with the Public Health England guidance.
Apparently, Laura meant NHS England, not Public Health
okay.
England. That's what she was meaning. Right, there's been from the point of view of questions, there's been quite a few. I'm sure that we won't be able to answer them all. I'm fairly aware that we might be having more of these webinars where we say we don't know. But oh, I thought we had Neil there. Right.
Flashback interview.
Yes.
Okay, I was conscious of time, so we have had a lot of questions. So just to let everybody know, so all the questions that you asked during the session, we're able to download them afterwards. So we do go through them and we try to look at what we can incorporate into future guidance and that kind of thing. But you can also submit questions into us. Before we close things off, I just wanted to let everybody know that there is another webinar planned for next week. There's some detail on the screen there, but that's going to be looking at the four-nation approach. So Lizzie will join us again to chair a panel of representatives from the four nations. So we realise there's a lot of questions about how things vary between different settings. So we want to talk about that in the next webinar. And then following on from that, we will go through the answers that you gave in the polls tonight to look at future webinars. We're talking and looking at the moment one around virtual clinics, for example, and lots of you talked about that tonight. So that'll be an interesting webinar for us to talk through. I'll just put one more slide up on the screen and it's Steph, if you could load the featured action as well. A reminder, if you do have any other questions, you can reach out to us on social media. You can email us at the policy inbox that's on the screen there. If you aren't a member at the moment, you can sign up for a newsletter where we send news out monthly. Lizzie, Marwan, thank you very, very much for another really interesting webinar. Is there anything else you'd like to add or any other comments before we close off tonight's session?
I'm sure Lizzie will be able to answer the non-steroidal comment that we haven't been able to get around to, but she'll answer us by email and I'll try and share it with as many people as possible.
No, just thank you for the opportunity. I think it's great to have these chats, and apologies you got me for a third time next week, but I'll be out of the hot seat and hosting, which will be quite a nice change. But thanks everyone for signing in. It's lovely to be able to have this opportunity to have a chat with colleagues and see what questions you're being faced with as well. So
thank you very much.
Thank you very much, everybody, for joining us. Thank you to our speakers. And to leave the session, you can just close the window and that will be it.